Hello, everyone, and thank you so much for joining for our inaugural collaborative symposium on the basics of neonatal kidney health. On behalf of the Neonatal Kidney Collaborative, the Education Committee co-chairs, Dr. Allison Kent and Dr. Jennifer Jatan, I'd like to welcome all of you to this really exciting day. My name is David Askenazi, and I currently serve as the board chair for the NKC. For those of you who might not be familiar with the NKC, we are a multi-center, multidisciplinary, multinational organization dedicated to improving the health of newborns around the world who are born with or put at risk for kidney disease through multidisciplinary research, advocacy, and education. The NKC started in 2013 as a group of 9 people sitting around a table talking about the needs and the importance of working together to improve care of babies and their kidneys. The one stipulation we had was that we had to work together with interactions between neonatology and nephrology. Today, our group includes 200 members from around the world. The NKC is a community where we work together to help one another make discoveries, educate each other and others about neonatal kidney health, and advocate for these children and those who are trying to improve their care. When the idea of this symposium was being discussed, Dr. Jatan and Dr. Kent imagined that there maybe would be 20 or 30 people participating in this collaborative, in this session. Instead, we have over 550 people registered for the symposium with representation from 60 countries around the world. We see all of you as part of the neonatal nephrology community that we envisioned, and we hope that in addition to learning something new today, you identify new connections, collaborations, and friends who are willing to make themselves available to help you reach your own personal goals. Megan?
Hi, everyone. I'm Megan Reagan, and I'm going to set some ground rules for today's symposium. We have 4 presenters who are going to be speaking for 25 minutes each, with an additional 5 minutes allotted at the end for question and answers. We encourage you to utilize the chat on YouTube. Ask questions as the presenters are speaking. As you think of things, just go ahead and throw it up there. Dr. Allison Kent and I will be keeping track of all of those questions. However, due to the large amount of participants we've had register for this symposium, we may not get to all of the questions today. If that is the case, don't fret. We're going to email out any of the questions that didn't get answered afterwards and try to, cover those as best we can. We do recognize there are a lot of ways, a lot of different clinical settings, a lot of different resources that are available to all of you. As Dr. Askenazi mentioned, we have 60 countries represented on this symposium today. So we have tried our very best to keep the content of the symposium as broad as we possibly can to make sure that it's applicable to each of you. Later on, we are going to award a couple of prizes. We're very excited about that. And so as we do that, I will contact the winners afterward on how you can secure those prizes. At the end, Dr. Kent is going to do the wrap up for us. She is going to pop a QR code up that we would like for you to follow. You can also get the link after the symposium in your email. And we really just want you guys to take this post-test to give us some feedback on what you thought was really great about the symposium and what we could improve on for future symposiums. So that is kind of everything on the ground rules side. The other biggest question I've had is, will this thing be recorded? The answer is yes. It will be on our YouTube channel afterward and also on our website, babykidney.org. So again, we are so thankful to have all of you with us today. It is my honor to go ahead and get us started. Our first speaker today is Dr. Andrew South. He is a pediatric nephrologist and associate professor at Wake Forest University in Winston-Salem, North Carolina. He is an NIH-funded translational physician scientist who investigates the epidemiology and mechanisms of the development and progression of disease across the life course using a causal inference framework. Dr. South has been with the NKC for a while now. We're very excited to have him with us today. Dr. South.
Great. Thank you so much, Megan, and thank you to the NKC and all of you out there in the world for this opportunity. I'm really excited to talk to you about this nerdy topic. To me, that's well and near and dear to my heart. So in addition to my research interests, as Megan kindly stated, I also direct our neonatal kidney clinic at Brenner Children's at Wake Forest Baptist Health. So in our neonatal clinic, we basically see all kids with congenital and or acquired kidney injury, either acute or chronic, up to 1 year of age after discharge from the hospital, whether it's the newborn nursery or the NICU. So I'm very interested in their short-term outcomes, but in my research interest, I'm also very interested in the long-term ramifications for their kidney health based on what happens antenatally as well as in early life, and in particular in the NICU for those individuals who are admitted to the NICU. So very excited to set up the stage for the talks to come, which is really, really cool. So without further ado, let's get started. So no conflicts of interest. I do have NIH funding that's directly related to this topic. So I thought we would talk a little bit about fetal kidney development. Obviously, that's an entire field in and of itself, and I am by no means an expert. I actually love giving talks on it because it is an excuse for me to learn it again and again and again. As with most things physiology related, you just have to do that repetition. Keep learning it, and eventually it sticks. So it's fascinating, and it's a very, very growing field, as we'll see in some of the data I'll show. But wanted to provide more of an overview. So don't worry, everybody, no memorization today, okay? Just a brief overview of it to set the stage for what's to come. Be it the things that occur antenatally, as well as postnatally, especially in those born preterm, and how those risk factors or exposures impact kidney development and kidney health in the short term and the long term over the life course. So that's really what we want to focus on today. And so the second thing we'll talk about is that implications for the NICU course. As I don't have to tell many of you, especially our neonatology colleagues, there are many comorbidities and acute and chronic conditions you all wonderfully deal with in the NICU that are directly or indirectly related to the kidney. So we'll provide a little bit of an overview about why that is, obviously, in terms of fetal kidney development, both in utero as well as postnatally in those born preterm. And that will really set the stage for the talks to come. And then we'll switch gears about the longer term implications across the life course. So what we really want to focus on is the important theoretical constructs that help us to understand this whole process and how we can best care for those patients and provide guidance to them and their families, as well as how we can guide research moving the field forward. So we can really impact patient care and improve outcomes overall. Something that's, despite the wonderful data so far, has still been a big knowledge gap in the field. All right, so hopefully you will come away today knowing some of the basics, or at least reviewing some of the basics of fetal and postnatal kidney development. Again, understanding this concept of what's called developmental plasticity. So in very simple terms, because I am by no means an expert, the short-term trade-offs that the fetus must make to improve short-term survival at the expense of potentially long-term deleterious changes due to early life exposures, not just in utero, but also postnatally as well. And then I want you to be able to start to apply a causal model and life course frameworks for this idea of programming of chronic kidney disease, often under the auspices of the DOHAD theories, or developmental origins of health and disease. This has been very helpful to me in my career just over the past few years in really understanding a lot of what's been going on and guiding not just clinical practice, but research as well. And as a resident and a fellow, I had no idea of these concepts. It was all since I've been an attending here at Wake Forest that I get introduced to these really fascinating topics that are pretty new still. All right, so fetal kidney development, early functionality. So, all right, buckle up because we're going to get a little deep here. So the pronephros and the mesonephros, everyone sort of kind of remember that from early training. I definitely had to brush up on that for today. So Basically, simply put, the very early antecedents of the mature kidneys develop even around 3 weeks post-conception, so very early on. We get early glomeruli or precursor glomeruli development by around 6 weeks post-conception. And this process of degeneration and involution is critical to healthy development of not just the kidneys, but the urinary tract as well. And so as many of you may remember, from the 3rd to the 4th weeks post-conception, the pronephros first develops with rudimentary tubules that then become, obviously, the mature tubules later on. Then the mesonephros develops with well-developed nephrons containing vascularized glomeruli with precursor proximal and distal tubular structures. And we'll see that in a couple of slides as we go through. So with the metanephros, the ureteric bud, so this little bud of tissue starts to expand into the metanephric mesenchyme. And then these S-shaped bodies, named because that's what they look like, are vascularized precursor glomeruli. So first you can see my very terrible cartoon drawing that I did way back when. And then I found this really great review in 2018 in JASN of kind of the newer findings in field development, which is really, really cool to read. So I shared some of those images here. So on the top left there, you can see the uteric bud, UB, where it is invading into the metanephric mesenchyme, which surrounds it in the top portion of that slide. And then you can see more of the ureteric bud epithelium developing off of the mesonephric duct there on the right side, with the actual histologic SSB, or the S-shaped bodies there on the bottom left on the right-hand histologic slide. So then these structures start to support and develop into the metanephros, which is the pre-kidney, if you will. So this could become vascularized by about 7 weeks post-conception and fully functional in terms of making urine by around 6 to 8 weeks post-conception. Full urine production usually occurs by about 9 weeks, with development of capillary loops and actual patent Bowman spaces by that time. So remember, Bowman spaces, that potential space in Bowman's capsule near the glomerular tuft where urine first collects. And then, or ultrafiltrate first collects. And then new collecting ducts are induced, as they grow, induce new nephrons. And this is ongoing throughout fetal life. And this fascinating series of images that I found in this JASN article were really, really, really cool. So this is in human developing renal tissue. JAG1 is stained that bright reddish orange color. That is the nascent nephron, so staining for nascent nephrons. And then in white is KRT8 staining for the uteric buds. So as you can see, as the uteric buds expand, they stimulate development of these nascent nephrons. And what we're going from left to right and then down to the bottom slide is over the course of several weeks of post-conception life, where you can have a few of these nascent nephrons and then it expands quite dramatically, as you can see in the bottom right. So I think this is really, really fascinating in vivo imaging that just makes me nerd out. So very cool. So I've always found this schematic very helpful for me to understand what this all means, what's going forward in time rather than just cross-sectionally, and especially how these precursor tissues develop into mature functional kidney units post-natally. So as you can see from left to right, we go from the uteric bud stage that we just reviewed with the metanephric mesenchyme in A and B, with development of early ureters and renal tissue in C, and then finally moving on to the close to matured kidney in figure D, with development of collecting ducts and the renal tubules themselves. And then in the little cutouts on the bottom, you can see the ureteric bud expands into the mesenchyme, which then becomes first the comma-shaped and then the S-shaped bodies, and then that becomes the precursor of Bowman's capsule with the glomerulus and endothelial cells with the early proximal tubules. What's really fascinating to me, and again, we're learning so much more about this with a lot of molecular development, is that the ureteric bud eventually becomes the epithelium of the collecting ducts, the pelvis, the ureter, and the bladder. And then the metanephric mesenchyme becomes the nephron tubules and interstitial fibroblasts to really support the interstitium of the kidney. The pelvis, the renal pelvis, and the major calyces, where the urine collects, is developed right around 10 weeks post-conception. All right, that's it for fetal development, I promise. All right, so why does this matter? Well, because the kidney starts to develop so early on post-conception and goes through most of gestational life, that's a critical window where if bad things happen, it can cause deleterious changes to kidney development and urinary tract development. And this can be intrinsic things to mom or baby, or to external factors, such as we often see in these exposures in the antenatal period and postnatally. And this directly impacts how we manage patients, or you all manage patients in the NICU, and their risk for developing comorbidities, both acute and chronically. So this critical postnatal window, especially once they're born, and especially if they're born preterm and need to be in the NICU. So that ureteric bud-induced nephron formation we saw on the past few slides doesn't stop at birth in those who are born preterm. It appears to go postnatally, maybe up until about 4 weeks, still trying to figure out the exact data behind that. But because in the fetal environment, that formation goes on till about 36 weeks gestation. Postnatally, if individuals are born very preterm, that only goes about 4 more weeks. So for example, if you have a patient born at 28 weeks gestation, they can have some ongoing nephron formation and maturation up until about 32 weeks gestation. They don't get to go the full complement of 36 weeks. So this has been a big foundation for the theories of oligonephronia, or reduced nephron number, and reduced nephron maturation and function. So this critical window, especially those first 4 weeks postnatally, is really, really important. And oftentimes where we see exposures causing acute kidney injury or other abnormalities that affect the kidney. The tubules also continue to mature postnatally. So we often talk about immature tubules or dumb tubules. But in all seriousness, the tubules are not fully mature, obviously, at birth, even in a term infant who's completely healthy. That's why they don't quite fully concentrate their urine and have quite diluted urine overall, and can be quite sensitive to fluid and sodium shifts, causing hyponatremia, for instance. So what we're seeing here on the schematic on the bottom is the generalized time course that we just went over the past few minutes, from conception all the way to birth, the pronephros, the mesonephros, the metanephros, development of vascularization and urine production, major calyces and pelvis formation, all the way up to nephrogenesis being complete. And as my colleagues, Dr. Carmody and Dr. Charlton, published a few years back, nephron number increases almost exponentially, but to some degree linearly, especially over that 20 to 36 week gestation period. So we can see quite high nephron numbers over that really critical window, with nephron number there being on the x-axis and gestational weeks being on the x-axis. So why do we care about tubular maturation? So it impacts a lot of what we do in the NICU. So it's not just the kidneys, quote unquote, or the tubules being able to function, right? It's various factors of their structure and function. So it's the evolution and convolution of the proximal tubule. It starts off not as convoluted and wiggly as it becomes more mature. And then the loops of Henle become elongated, really down into the deep medulla to improve that urine concentration ability. The tubules over time, postnatally, increase the number of transporters for all solutes over this time. And the various isoforms of those transporters and co-transporters change as well over those first 4 weeks of life, and even the first 2 years of life, not just in preterm infants, but those born term as well. Signal transduction also changes in these transporters. So it's various levels of the transporters themselves within the tubule that impacts to what extent we see abnormalities develop in the NICU. And finally, there's blunted hormonal control. So sex hormones, ADH, for example, the renin-angiotensin system, all of these major factors on kidney structure, function, and development. There's blunted hormonal control postnatally that has an effect on tubular maturation. And one of the big factors in this maturation of the tubules and the need for the tubule to have increased reabsorption is to counteract changes in increasing GFR over the first several weeks of life, as we'll review in subsequent slides, as we see that in utero shift to the postnatal life with fetal blood flow. So what are some of these clinical consequences? We're not going to go through them in detail, and we'll cover a lot of these in subsequent talks later today by people much smarter than me. But here's just a few of the things we can encounter. So a lot of this occurs because of proximal tubular dysfunction due to some proximal tubular immaturity that we just discussed. So these infants can spill glucose in the urine, generalized aminoaciduria, almost like a Fanconi syndrome type picture, but it's more physiologic than pathologic. It can affect a lot of their drug metabolism, right? So a lot of the drugs that you'll need to give in the NICU changes substantially based on gestational age of the infant and how many postnatal weeks they are alive. They typically have a low bicarb reabsorption threshold, so that can really impact their development of metabolic alkalosis or acidosis, as well as how they respond to a primary respiratory acidosis, right, which is a big thing that we deal with in the NICU. And then sodium wasting. How often do we see patients with hypo or hypernatremia? All the time. So again, their urine is relatively dilute because those loops of Henle are not fully elongated and those tubular transporters are not fully mature. And so they're exquisitely sensitive to that, especially the iatrogenic fluids and solutes that we give them to maintain other important life systems, right? Because things like the heart and the kidney and the lungs, they are very important. As much as a nephrologist is a little bit reticent to say that, it's very true, right? And then urine acidification is obviously affected and the risk of hyperkalemia. So all of these things are clinically significant things that impact our care in the NICU, and this is one of the major reasons why. One of the things that surprised me the most as a new faculty several years back, I won't say how long ago, was this increase phosphorus maturation, actually. So even in relatively preterm born infants, the phosphorus regulating transporters in the tubule are almost fully or fully mature at birth. And I was shocked about this, given what we just talked about. And I was actually studying for nephrology boards when I learned this by reading the old textbooks. We need, as developing infants and humans, a positive phosphorus balance to promote overall growth, as well as organ growth and brain growth in particular, and not to mention skeletal growth, right? That's such a critical period and rapid period of growth and development. So the body has maintained this ability to have this exquisitely sensitive phosphorus balance. So even the immature kidneys in term or preterm infants is relatively, compared to other solutes, very good at retaining phosphorus to maintain that positive phosphorus balance. Doesn't mean that phosphorus issues don't occur. They obviously do. But in terms of maturation of tubular transporters, I was surprised to learn that several years ago. Briefly mentioning neonatal kidney hemodynamics, because that comes into play when we deal with acute kidney injury and patent ductus arteriosus and many other conditions that you all are much smarter at managing than I am. There's a lot of shifts that occur from the fetal to newborn transition, right? And they all impact the kidney, and the kidney, in terms of healthy kidney function and appropriate vascular response, is needed to maintain a safe passage through the transition. So we see increased renal blood flow, we see decreased renal vascular resistance, we see a pretty marked increase in glomerular filtration rate over the first few weeks of life, but even up to 2 years of age. We often see GFR doubling by 2 weeks after birth and adult levels by 2 years of age, with the exception that we can see a significant lag in those who are born preterm. So for instance, there are studies where infants born very low birth weight can reach a normal GFR up to age 8 years, where their term or otherwise healthy compatriots maintain that or reach that adult threshold GFR by 2 years of age. Renal blood flow can increase fivefold from 5 to 25% during this transition, primarily to the outer cortex. So that's why the infants are exquisitely sensitive to acute kidney injury in the periphery of the kidney if there's any decompensation in overall perfusion. And then that decreased renal vascular resistance is in part due to new nephrons that are developing and maturing up to 36 weeks or shortly thereafter, before then in those who are born very preterm, and some decreased glomerular arteriolar resistance that is heavily influenced by prostaglandin and the renin-angiotensin system and other hormonal regulators that can be very much impacted by all those things that we have to do in the NICU. Okay, so you all have taken a great care of them in the NICU. They are safe to go home. They're thriving. They're doing well. So what do we do from here as nephrologists and individuals interested in that neonatal kidney space, right? Does what happened early in life and antenatally affect their long-term outcomes? The short answer is yes. The longer answer is it's very complicated, and we're really still in our infancy in terms of elucidating clinically and epidemiologically true causal relationships. And why is that important? Because that's what directly impacts clinical care and population health to improve outcomes. We really are still trying to figure out a lot of these relationships so that we can actually improve these outcomes. So that's still a major knowledge gap in the field, and that one that really interests me in this whole approach. So for those who may not be as aware, and again, I did not know anything about DOHAD. I had never heard of the term until I became faculty and work with people much smarter than me who are big in this space. So the developmental origins of health and disease, or DOHAD, this theory that environmental factors influence the embryo, the fetus, and the young child and older children in their growth and development across their early life course. And it impacts their well-being and can impact their risk for many diseases later in life. So these antecedent exposures that occur years or decades before the onset of overt adult disease. So Dr. Barker was preeminent in developing this DOHAD theory in the late 80s. And interestingly for us nephrologists, this occurred really at the same time that Dr. Brenner was developing his unifying hypothesis for low nephron number and why the kidneys fail. So it was this fascinating historical perspective of these two complementary theories developing hand in hand. And we've really seen an explosion in this field just over the past 30 years. Obviously, I had nothing to do with this early work because I was an infant not too long ago when this all came out. So, but this really helps our understanding of how these early life factors and incidental factors can impact health over the long term. So it's sadly not just in the NICU and you're out of the woods once you're discharged, but there are potential risks throughout their lifetime that we need to be aware of and to teach the patients and their families as they grow up. But what those specific risks are and what we can do about them, we're really trying to figure that out. So direct offshoots of DOHAD, and again, trying to reconcile a lot of these knowledge gaps and paradoxes in the field are really important things. So DOHAD has exploded to include a lot of additional external exposures, not just the health of mom, baby, and dad, but also environmental exposures. Recently, a lot of good work on social determinants of health, unmet social needs, adverse childhood experiences, all seem to have some kind of causal role. Again, we have no idea what those roles are yet, but really good work moving forward to understand those things. And this paper by Raju and I from a few years ago has this great schematic that really lays out this life course model with different exposures that can influence these individuals after NICU discharge. And then Dr. Chevalier, UVA, and others have really been developing over the past 5 or so years this evolutionary adaptation theory to apply to DOHAD, where this developmental plasticity occurs because of needing to maintain energy and not waste energy and oxygen consumption and various other solutes. And so the schematic here on the right really shows that, but not just in fetal life of postnatally how epigenetic modifications could further influence this programming of disease. So it's really not just in the antenatal period and the immediate postnatal period, but really is over the whole life course into adulthood as well. So this life course model within DOHAD is really important for our understanding and to really contextualize things, both clinically and for research. Okay. So here's just an example of a meta-analysis that looked at, is there increased odds for chronic kidney disease and kidney failure with dialysis overall? So this was 32 observational studies. Obviously, we can't really do a clinical trial in this space, which is why it's really, really important to get scientific rigor right the first time when we do this work, and as us as clinicians, to really critically appraise the literature to really help translate these findings to our patients, but also not to do harm and not to overemphasize some of these things as well. And I speak from personal experience, always have been guilty of things like that. In this meta-analysis, half these studies, so 16 out of the 32, reported a significant association between low birth weight and risk of chronic kidney disease, while half reported a null result. The overall effect, highlighted with the red bar, suggests an increased odds for kidney disease. And this is overall. So this is albuminuria, kidney failure on dialysis, and CKD with low estimated GFR. So that's a pretty broad spectrum of severity. And so a lot of the issues that have occurred in studies today, including my own, before I knew better, is that we tend to overemphasize these things. And we really need to have good scientific rigor to best understand these things. This meta-analysis is fascinating because it was over 50,000 individuals with record linkage data of over 2 million people as well. So pretty robust. And again, there's a signal there, but what does it mean? And as we'll talk about in a few slides, is it preterm birth itself or the antecedent reason mom delivered preterm that was actually the causal effect, or was it a combination of the two? That's where we're stuck. All right, so just a little bit about our own data and how I personally got into the space. And individuals, my mentors who taught me about DOHAD in the first place. I joined our prenatal events postnatal consequences PEP-C study when I joined the faculty at Wake Forest. So simply put, we have a cohort of individuals born preterm with very low birth weight in the 1990s who are now in their late to mid 30s that we've been following since they were age 14. This is data from PEP-C1 at the first set of study visits when they were 14 years of age. And we showed amongst those who had blood collected of an N of 96 compared to a term control group who were born without very low birth weight, we showed not only did they have lower estimated GFR, but they also had higher blood pressure as well, and a higher proportion of high blood pressure. So systolic at or above 120 and diastolic at or above 80. Of interest though, in this pretty...
We're just a bit over time, so we might have to wrap up in the last quick slide or two.
Sure. All right, so sorry everybody, things are complicated. So again, what's the exposure, what's the outcome? Is it preterm birth itself, or is it antecedent factors? And then it's super complicated. So sorry about going over everybody. Thank you for your time. I wouldn't be here today without our amazing group and my mentors. And thank you again to NKC for this opportunity. Thanks.
Thanks so much, Andrew. That's been fantastic. We do have one question from Tom Forbes, who I think is here in Australia. Tom sort of asks, what do we know about the physiology of GFR increase over the first 2 years of life?
Yeah, so obviously it's different in which patient population you're talking about. So term compared to those who were born preterm and or with low birth weight or very low birth weight and so forth. So a lot of it has to do, especially in the first few weeks of life, that change in vasculature, right? And the change in renal vascular resistance and renal blood flow overall, and then that decrease in glomerular arteriolar resistance as well. So one of the very challenging things in the field, and especially for me, is what's pathologic changes in estimated GFR, especially in the hospital, and what's just physiologic. And so a lot of that has to do with our understanding, which I still think is incomplete, about what is actually physiologically going on with that change in estimated GFR, and then again teasing out what's pathologic versus physiologic.
Yeah. And so the second part of his question, he said, if we don't have capacity to make new nephrons, what is it that allows GFR to increase?
Yeah, so again, a lot of it is the change in vasculature. And then the nephrons themselves that we do have do develop and mature. So yes, we don't lay down new nephrons postnatally, but the ones that we do have mature and grow in size. So that has effects on the vasculature and the ability to process more blood, more filtrate per unit time and per unit body surface size.
Great, thank you very much, Andrew. That's the questions that we have for the moment. For those of you who are online, please feel free to put your questions on chat. And one of the questions that came up also was, are these sessions being recorded? Yes, they are, and Megan is going to be fantastic, and she's going to get them popped up on the NKC website later, but they'll also be available here on the YouTube. So just so that everyone knows that these sessions are going to be available after the session. Back to you, Megan.
Thank you very much. Thanks, Andrew. That was a wonderful presentation. Up next, we have Dr. Mina Hanna. He is an associate professor of pediatrics and the director of the Neonatal Intensive Care Unit at the University of Kentucky. Dr. Hanna focuses on mechanisms of renal development and injury in preterm infants, as well as long-term consequences of AKI in that group, which is why today we've asked him to give us a talk on neonatal AKI. So Dr. Hanna, take it away. Sorry, everyone. It seems Dr. Hanna might be having some technical difficulties.
Can you hear me? Sorry about that.
It's okay. We can hear you now. It is all yours.
I'm not able to share the screen.
Andrea, are you still sharing your screen?
Nope.
Perhaps, Megan, if you can show Mina's slides, and
Yeah.
Mina, if you can just tell Megan when to forward to the next slide.
Yep, we will do that in 1 second.
There it goes.
Excellent, Mina.
Can you see my slides now?
Yes, we can.
Perfect. Okay. And I really also want to thank the NKC for this opportunity. I'm gonna be talking about the AKI definition and the outcomes from AWAKEN and other studies. I have nothing to disclose other than I'm not a nephrologist, obviously. I'm a neonatologist who's interested in neonatal kidney. The objectives of what I'll be talking about today, reviewing the definition and incidence of neonatal AKI, examining the association between AKI and other neonatal outcomes, and reviewing recent studies exploring the risk factors and the outcomes of neonatal AKI. So a little bit of history about neonatal AKI or AKI. It was first described in World War I and World War II when it was noticed that blunt trauma to the abdomen induces oliguria in combatants and resulting in crush syndrome. And then in the 50s and 60s, the first cohort where AKI was described were post-operative cardiac patients. In the pediatric literature, it was first described as hemolytic uremic syndrome in the mid-50s. However, now that the epidemiology of AKI has changed because the care of neonates and pediatric patients has improved. There is more research in pediatric patients showing that even small changes in serum creatinine may be significant. And AKI is an independent risk factor for morbidities and mortality in neonates. And neonates with AKI are at higher risk for developing chronic kidney disease later on, as we heard, and hypertension. So how do we define AKI? The textbook definition is a reduction in GFR to a level that's insufficient to adequately filter and excrete solute and water and maintain fluid and electrolyte balance. The challenge is how do we change that or take that to the clinical setting. So some of the older definitions that have been used for AKI are listed here. One is using the urine volume below 0.5 to 1 cc per kg per hour. However, in neonates, most AKI are non-oliguric, and the urine volume is a poor indicator of renal function. Another definition using serum creatinine value, absolute value more than 1.5 milligram per deciliter. And we'll talk about the limitations of using serum creatinine as indicator of renal function. The definition that's close to what's widely accepted is the rise in the serum creatinine. We don't have a reliable way to measure GFR in neonates, and probably waiting for the need for renal replacement therapy is too late. The limitations of serum creatinine is that there is a lag between the initial renal injury and the serum creatinine rise. So by the time the creatinine starts rising, about 25 to 50% of the kidney function has been lost already. It's also, it reflects the kidney function, not the kidney injury. It does not differentiate the specific site of the renal injury, and it's affected by medications, bilirubin, and muscle mass. And it may overestimate the renal function because of tubular secretion of the creatinine. And once renal replacement therapy is started, it removes creatinine, making the prognostication difficult. Also added to that, in the neonatal population, initial postnatal creatinine reflect maternal values, and creatinine and creatinine clearance changes as growth and renal development occur. So the most widely accepted AKI definition in neonates is based on the modified KDIGO definition that has 3 stages for AKI using the serum creatinine or the urine output, and using the reference value as the lowest previous value. if we look on the epidemiology of AKI in pediatric population, about 1/4 occur in neonates. So it's quite common in neonates. And there are some high-risk groups in neonates. So preterm definitely are one of the highest risk group for AKI, and we'll talk in depth about that group. But the other high-risk groups are term babies with HIE, babies with congenital heart disease, and babies who need to go on ECMO. So what do we know from either single center trials or small cohort trials about the outcomes of AKI in those groups? So we know that from this study that babies with HIE who were treated with therapeutic hypothermia, those who had AKI had longer duration of NICU stay, longer duration of hospital stay, longer duration of mechanical ventilation, and higher mortality. Babies with congenital heart disease similarly also had longer ICU stay, and babies with severe AKI defined as stage 2 and stage 3 had longer duration of mechanical ventilation and increased post-operative inotropic need, and also higher mortality. And the last group are the babies who needed ECMO. From this cohort also, if they had AKI, they had longer ECMO rounds, longer duration of mechanical ventilation, and higher mortality.
Minna, is it possible for you to put the presentation on slideshow just so that the slides are a bit bigger for people to view?
Is it on slideshow now?
Not.
No, if you go to the tab at the top, it says slideshow. You should be able to, yep, there. Oh.
Is it slideshow now?
No.
I'm not sure why it's showing.
Do you have two screens open, Minna?
Mina, there's a tab that says slideshow at the top, but if you can't get it to go, I think we can keep going.
Yeah.
Is it? I'm not sure. Is it showing now?
No, you're back at the first slide.
There's a little tab at the bottom right-hand side as well that you can use. That's right next to the slider at the bottom.
Yeah, I tried both of them.
Okay, no worries. We'll keep going. We don't want to interrupt you too much.
Are you
That's great.
seeing the?
Yeah,
Okay.
that's great. Keep going. You got
Sorry
it.
about that.
Take your time.
Sorry about that. So the first big trial that I'll be talking a lot about today is the Awaken trial. So this was a multi-center international collaborative. I think there was one center in India and one center in Australia, and the rest of the centers here in the US and Canada. Inclusion criteria was fairly simple, including babies who were admitted to the NICU and received IV fluids for more than 48 hours, and excluded babies who were admitted with either lethal congenital anomalies or who had cardiac surgery in the first 7 days of life. So this large epidemiological study screened more than 4,000 babies and enrolled a little bit over 2,000 in this cohort. And there are currently more than 20 papers who came out of the Awaken trial. And the important issues that we've learned from the Awaken trial are looking at the incidence and outcomes in neonates, the risk factors for AKI, and dividing it into early and late AKI. Early defined as AKI that occur in the first week of life, and late as defined that AKI that happen after the first week of life. And also looking at the association with, of AKI with other comorbidities like IVH, BPD, and fluid balance. And before talking about the incidence, I think an important issue that the Awaken trial looked at was the AKI definition and how to optimize it in the first week, looking at the absolute value and the percent change in serum creatinine and then the maximum change, and determining what's the best that can predict the mortality outcome with high sensitivity and specificity. And looking at that cohort, it was found that unique serum creatinine rise cutoff for different gestational age improved the outcome prediction, and that the percent serum creatinine rise does not add value to the neonatal AKI definition. And as you can see from the graph on the right, that as the serum creatinine, whether the absolute or the percent change rise, the chances of mortality also increases. Looking at the incidence of AKI, so it was like a U-shaped incidence with a high incidence in the small babies less than 29 weeks, 48% in the babies less than 29 weeks, and 37% in baby in late preterm and term babies more than 36 weeks. However, it's important that in babies who are born between 29 to 36 weeks, in that group, the incidence was not insignificant. It was around to 20%. And looking at outcomes in this large cohort, AKI was independently associated with mortality and increased duration of hospital stay. And looking only on the group of babies who had neonatal HIE in that group, similarly also they had longer duration of hospital stay. looking at risk factors and dividing AKI as early and late. And I think this probably was the first study that looked at neonatal AKI and divided as early and late. So similarly also with early AKI, it was noted that there is an increased risk for mortality and increased risk for hospital stay. And there were some factors that increase the risk for early AKI. Those are admission to a children's hospital, and if the admission is for a surgical reason or for a high bilirubin, those were those were factors that would increase the risk for early AKI. Some of the maternal factors like prenatal steroids and hypertensive disease of pregnancy were also associated with lower risk of AKI. However, that was not significant after adjusting for center effect. I think it's interesting here that the use of antimicrobial and some of the medications that are nephrotoxic was associated with a lower risk of AKI. However, that's possibly because of the high exposure in this cohort. Looking at late AKI, similarly also there were some factors that increased the risk for late AKI. Some of those are the need for intubation or the diagnosis of NAC. I think it's interesting that in babies in that cohort, for babies who had late AKI, about 28% of them had experienced early AKI. So that's potentially increasing the risk for long-term chronic kidney disease. And as expected with increased number of serum creatinine measurement, there's potentially higher correlation with AKI prevalence. Another also risk factor for AKI was a low hemoglobin, and in the first postnatal week was associated with late AKI. So that association was no longer after fluid balance was included. And then the last risk factor I'll present is the low albumin level that has been shown that to be associated with early and late AKI, whether looking at an albumin level less than 2.2 or between 2.3 and 2.6, it was significantly associated with AKI. Some of the other morbidities that have been shown to be associated with AKI in that cohort, one is IVH. So in the babies between 22 to 28 weeks, there was a significant incidence of IVH. And we've also shown something similar, especially in babies who had positive fluid balance. They were at higher risk for IVH. The other morbidity, and I think we'll hear more later about this, is BPD. So in the awakened cohort, babies less than 32 weeks who had AKI were also at higher risk for worsening lung disease, whether BPD for babies less than 32 weeks or chronic lung disease for babies older than that. So there is a crosstalk between kidneys and lungs, which I think is interesting for neonatologists. There is actually animal studies that have shown that AKI triggers a cascade of inflammation that makes lung disease worse, and that earlier initiation of peritoneal dialysis or renal replacement therapy improve those outcomes. And then the last morbidity that was looked at in the AWAKEN cohort was the fluid balance. And it was shown also that a peak fluid balance in the first week that's positive or on postnatal day 7 has been associated with increased risk of mechanical ventilation. And that has been shown in the preterm group and in the near term and term group. So what do we know about some of the long-term outcomes for babies who have AKI? This was a small cohort, looked at 20 babies after discharge from the NICU with a follow-up around 7 years of age. And about half of them ended up with some degree of renal dysfunction, with 4 ending up with chronic kidney disease and 5 progressed to end-stage renal disease. Similarly, also, Dr. Hare showed that in a small cohort of babies that had AKI in the NICU and have been followed at the median age of 5 years, they had a lower GFR, with the lowest GFR in the group of babies who had severe AKI. So not just babies who have AKI are at risk for chronic kidney disease, but also, as we heard, prematurity itself puts those babies at risk for developing chronic kidney disease later on. This was a study looking at autopsies from 28 kidneys from preterm neonates and comparing them to stillborn gestational controls. And as you can see that the kidney weight was significantly increased with increasing post-conceptional age. And compared with gestational control, the preterm neonates had a significantly increased kidney to body weight ratio. And what they found is that in the preterm kidneys, they had a higher abnormal glomeruli compared to gestational controls, and also had significantly larger cross-sectional area of the renal corpuscle, suggesting again the renal hyperfiltration that we heard about. So again, that would put those babies for at higher risk for chronic kidney disease later on. We also know that growth restriction, whether intrauterine or extrauterine, puts those babies, preterm babies, are at higher risk for chronic kidney disease later on. And we heard about this large this systematic review of several observational studies that have shown that low birth weight is a risk factor for chronic kidney disease. And I think it's important to note, so this is a little bit old, probably 15 or 20 years old observational studies looking at babies less than 2,500 grams. And as the care has improved and we're taking care of babies less than 500 grams, I think that's probably their outcomes probably going to be at higher risk for chronic kidney disease. So what I've seen that prematurity predisposes those babies for is a risk factor for acute kidney injury. And acute kidney injury is a risk factor for chronic kidney disease. And prematurity by itself is a risk factor for chronic kidney disease.
Mina, you've got 1 minute.
Okay. The other study I want to mention is the repair. There was an ancillary study for the PEANUT trial. The PEANUT trial was a randomized trial looking at the effect of erythropoietin and long-term neurodevelopmental outcome. So this was an ancillary study to the PEANUT trial looking at erythropoietin and kidney outcomes. And similarly, also in that cohort for babies less than 28 weeks, between 24 to 28 weeks, the AKI was about 38%, so it was quite common and associated with mortality in babies who had severe AKI. Some of the risk factor for the renal outcomes, and I think it's important here that in this cohort, 18% had chronic kidney disease. That was the primary outcome, defined by GFR less than 90. And 36% had albuminuria, and 22% had high systolic blood pressure, and 44% had high diastolic blood pressure. Erythropoietin was not did not show a significant improvement in renal outcome, except for the systolic blood pressure more than the 90th percentile. However, I want to talk finally about another potentially protection for acute kidney injury that came out of the AWAKEN, and that's the caffeine. That has been shown that babies who were exposed to caffeine had lower incidence of AKI, with a number needed to expose quite small, actually. And then finally, if there is one thing that we can immediately change, I think, is how we better document the incidence of acute kidney injury in this group. As you can see here, we're not doing a good job documenting the incidence of acute kidney injury on those babies. And again, I'd like to thank the NKC, and I'd encourage all the trainees to visit the Baby Kidney org website. It's full of excellent resources.
Thanks, Minna, for a great wrap-up of that. We do have one question for you from the viewers. Do you think IVH and AKI had anything to do with BP fluctuations as a consequence?
I think that's an interesting question. I'm not aware of any study that looked at that, the effect of blood pressure and AKI and IVH, but I think physiologically it makes sense that that's possible.
Right. And just wondering, what does your centre do as far as following up babies that have had an acute kidney injury?
Yeah, I don't think there are. The guidelines are a little bit vague, I think, about follow-up. The AP guidelines is only measuring the blood pressure. What we do here is that babies who come back to the NICU grad clinic, we do blood pressure and urine albumin. And if there are any abnormalities in the last visit when we're seeing them at 2 years of age, then we make sure that they're referred to the nephrologist so that they have a continued follow-up. And I think different institutions are doing similar to that.
Great. Excellent. Thanks so much, Minna. Over to you, Megan.
Thank you. Thank you. All right. So if anybody has been paying attention to our schedule, you would see that the next doctor, Dr. Jennifer Japan, who is one of our co-chairs, unfortunately is not with us today. So our board chair for the Neonatal Kidney Collaborative is going to be taking over for her talk. Dr. David Ashkenazi is a professor and endowed chair in pediatric nephrology. He is also the chief scientific officer for Zoraflow, and all around just very knowledgeable on neonates, infants, AKI, dialysis. So Dr. Ashkenazi, you have the floor.
Great, thank you. Can you guys hear me and see my slide?
Yes.
Okay. So this is a talk that I can spend 2 days talking about, but I won't. What I'm going to do is provide you insights that are geared towards someone who's learning about neonatal dialysis, for the neonatologist or a resident or fellow who or young attending who may want to learn more and really kind of focus on what are the decisions that need to happen in the NICU as it relates to dialysis. I'm not going to go into great detail about some of the intricacies of the prescription, but really kind of try to stay broad here. And as Megan mentioned, this was really put together by Jennifer Jatan, and I'm happy to share the slides that she shared with me as we move forward. So she does not have conflict of interest. I do, and fortunately, I work with 3 companies that make dialysis machines and are trying to make them better for neonates, and I'm going to be speaking about some of those here today. So the objectives are to describe the basic physiology of and prescribing principles for peritoneal dialysis and continuous kidney support therapy for neonates and infants. We're going to highlight the aspects of clinical care that are important for discussing during daily rounds and nephrology rounds when babies are receiving dialysis. Again, this is not a comprehensive course on neonatal dialysis, but there's lots of resources out there if you want to learn more. At the PAS in 2023, there will be a postgraduate course, and I believe there'll be several sessions on neonatal dialysis that you can get. We run a course here at UAB and Children's of Alabama called the NICS course. It's a 1.5-day course that you may be interested in. And the Iconic group is a registry, but also a collaborative that's looking at quality improvement in centers that are doing dialysis with neonates using the Carpe Diem machine. The first thing that I want you to take home with you is that infant dialysis is a team sport. It can't just be the nephrologist running it. It can't be the neonatologist and the intensivist doing it on their own. It's really a team sport that involves not only physicians, but dialysis nurses, whoever's going to put in your access, palliative care, pharmacists, nutritionists, and certainly the bedside nurses. And at the center of it all has to be the family and the patients. We have to be able to include them in our conversations, in our decision-making process. As I think about what is the most important things to know, I step back and say, well, what is kidney support therapy or dialysis? What is the goal? What are we trying to do here? Well, we want to control and maintain homeostasis of electrolytes, water, and uremic toxins. We want to allow for fluid provision with all the things that are necessary to help a child grow and be successful and walk in and out of the hospital. We want to maintain the circuit running because it keeps everybody happy, and downtime is not fun for anybody. And we want to decrease the risks that are potential in taking care of these kids. We don't want to cause problems with blood exposure, hemodynamic instability, access issues, and infections. And importantly, in the neonatology world, in the NICU, we don't want to freak people out. Historically, that's been one of the reasons why many people have avoided doing it, is because in the past, you have to have crash carts open and patients would crash, and people hated this therapy because it was so difficult. We and others are now showing that it's not such a big deal. So part of our program is to make sure that people understand what's happening. And this opportunity today helps us do that. It's also important for people to know and families to know that kidney support therapy or dialysis doesn't do anything to fix the kidney. We're just doing the job of the kidney. One of the things that's very important for neonatologists to understand is when to start organ support therapy. Every decision that we make in medicine, whether it's starting an antibiotic or starting IV fluids or putting a patient on a ventilator, comes with risks and benefits. And so I ask you, when do you start a patient on ventilatory support? Usually it's when people start to see that things are going the wrong direction. And if you don't do anything, things are going to get worse. It's going to make your life more difficult. The pH is going to be worse. The body's not going to function as well. That's when we start. So when there's impending harm from the inability for the organ to do its job. When do we start blood pressure support? It's not when the blood pressure gets to 0. It's when you see that there's ischemia, you see that the lactate's going up, you see that the perfusion is not well, you see that cardiac is having trouble, and you support that organ. Same with nutrition support. And I would argue that that's the same thing we need to do when we start thinking about kidney support therapy. So when medical approaches are not likely to alter the impending harm of the inability of the organ to do its job, that's when we should start. It's a matter of benefits and risks. And again, reminding you that the kidneys have to do certain things, and if they don't do their things well, you can get uremic, you can have electrolyte issues, but mainly the reason we're starting kidney support therapy in our program and across the country is to maintain the fluid balance. And this includes the ability to provide nutrition. So if you can't give nutrition to a baby, they're not going to grow, they're going to get sick. That's an indication for kidney support therapy. The other thing that's very important for you guys to take away from this is that as nephrologists, we need to know early before the issues are getting worse. We want to be part of the maximal medical management. The last thing we want to do is put the patient on circuit. We want to be there to avoid this and prevent this from happening. If you call us too late, we won't be able to help you with that process. So call us early so we can maximize medical management. We're going to think of 1 or 2 things that we're going to want to do and see before we put the patient on circuit. We want to be able to meet the family and the patient. We want to be able to get a sense to what's going on before it's an emergency. And we need to plan by contacting our team, contacting our surgeons, start thinking about which modality is going to be best, PD versus hemo. And it's important sometimes because the NICU has to plan their nursing coverage in case tomorrow we're going to need dialysis. Now, I'm shifting to a couple of basic principles that you have to understand. So the first is something called ultrafiltration. This is the process of removing water. You're not only removing water when you take fluid out, you're removing everything that comes with it. So a little bit of salt, a little bit of chloride, a little bit of potassium. But don't get this mixed up. Ultrafiltration is simply you're removing water and whatever's coming with it. Now, diffusion is a process whereby if you have an area on the left side that has a high concentration, through a semi-permeable membrane that has little tiny holes, things move across to find equilibrium. So it's the movement of solids from high concentration to low concentration. That's what we learned in 7th grade science. Convection is a term that confuses people. And I use the analysis that the convection is like a coffee filter, whereas diffusion is like a tea. So convection is basically shoving fluid through this membrane and pulling it off. So if I dump a liter of water into my coffee filter, when I look at the bottom of the coffee, it's not just water. I've dragged all those coffee molecules into the pot of water. If I dump that pot of water in the trash, I've now cleared all those wet products. So it's essentially ultrafiltration, but I'm adding water to the top and taking that off. So that process is called convection. Now, as we think about what to do with babies when they need kidney support therapy, it's important to recognize that there's lots of tools available now that weren't available before. And so when I think about the success of our program, it's not just that we're able to do one thing, but we like to have different tools because certain things that happen to patients, certain characteristics of the patients, certain goals of therapy may want you to have one tool versus the next. So let's talk a little bit about PD versus extracorporeal therapy. Peritoneal dialysis is cheaper, it's easier. The catheter should ideally not be used for a while if you can avoid it. There's some, but not perfect ultrafiltration control. It's a little bit more of kind of the witch's brew and you're trying to guess how much fluid's going to come out. And it's certainly ideal if you don't have the ability to do blood dialysis. Alternatively, blood dialysis is more expensive, requires more training, but it gives you very tight hour-to-hour control or minute-to-minute control if you wanted it. The one advantage is that you can use the catheter immediately, and there's no fluid in the abdomen that can affect your GI and lung issues. And certainly it's ideal if you don't have the ability to do PD. For example, if you have someone with gastroschisis or has had necrotizing enterocolitis, example. And remember that these modalities are not one better than the other. They're complementary, and we need safe and effective options for kidney support therapy in neonates. So let's talk a little bit more about PD. So you can see here in the in the left corner, there's a PD catheter. It's got two cuffs many times if you have enough fat for the baby. If you have really skinny babies, we're only using one cuff these days. But you have two cuffs that kind of live like this that help secure this in place. And sterile dialysis is introduced into the peritoneal cavity through a catheter. Particle removal happens through diffusion, and fluid removal happens through ultrafiltration. So in this bag, what you can think about, if there's sodium of 140 and potassium of 0 and urea of 0, and potentially a lot or a supralot or a lot of supralot of dextrose, and you dump this into the belly, then what happens is that as it fills, there's a period of time where it kind of starts to equilibrate. And so what would happen if your patient's potassium is 7, for example, some of the potassium would go from the patient's blood into this fluid. And then after a while, you would dump that fluid into the effluent collection, and then you throw it in the garbage, and now you've cleared potassium. Same thing with urea. If you have high urea in the patient, it'll equilibrate and get removed this way. And then the sodium may not change much if it's in an equilibrated system. Now, the fluid is removed through dextrose concentration. The higher the concentration, the more water is going to try to equilibrate. And so the higher concentration of dextrose, the more fluid you can pull off in a certain cycle. Now, we have been doing dialysis for 7 decades using peritoneal dialysis in children. The procedure really hasn't changed very much, except for people have realized that you can use almost any vascular catheter that you have available. If you're in a country that doesn't have PD catheters, you can use a pigtail catheter that you may use for a chest tube or for a PD drain. Certainly there's better catheters out there, but people have been doing this around the world for 7 decades. It's relatively simple to learn, but the main problem is that the catheter may leak and or get infected, which then makes your procedure very, very difficult to perform. And as I mentioned, clearance and ultrafiltration is not as precise as with hemodynamic, as with blood CRRT. The sample prescription is we would do manual cycles in neonates, start at about 10 mLs per kilo, do cycles where you do 10 minutes to fill, 45 minutes to dwell, and 5 minutes to drain. There's no anticoagulation. And we can change the dextrose concentration, between the 1.5, 2.5, or 4.25 to drive how much fluid is removed. And you can essentially do that on the fly. Now, when we talk about extracorporeal blood dialysis, there's a couple of terms that I need to present to you, not to confuse you, but just to show you that all we're doing when we mention these weird terms is we're just saying, are you doing ultrafiltration without clearance, such as scuff? Or are you doing the coffee filter filtration, CVVH? Or are you doing the T analysis where you're doing diffusion? Or are you confusing everybody by doing convection and diffusion with CVVH-DF? Again, I mentioned these not because you have to memorize them, but because your program is going to be doing one or the other of these. And schematically, what you could see is that if we do aquapheresis or ultrafiltration, we're just pulling fluid from the circuit. Imagine a little straw there where that yellow thing is. Imagine just sucking on this fluid over here and just pulling off that fluid and dumping it in the trash. If we're doing replacement fluid, the coffee filter analysis, we could do it before the filter or after the filter, pre or post CVVH. Dialysis is countercurrent or co-current, but you can have CVVHD this way, or you can do both in that schematic. So this is just a brief timeline that I want to show you as it relates to Aquadex, Carpe Diem, and the HF20. The HF20 has been around for really since 2009. It came to the United States as a trial in 2016, and it's been approved in 2020 for use in children less than 8 to 10 kilos. The Carpe Diem, first in human, was in September 2013, approved in the FDA, has been used in Europe, and then it was approved in the United States in 2020, and shortly thereafter, our friends in Cincinnati put the first patient on. We've been using a modified version of the Aquadex since 2013, and it's FDA approved now for ultrafiltration only for children above 20 kilos. So we've been using it off-label during this whole time. This is a picture of the Carpe Diem. It's built from the ground up to be designed specifically for neonates. It has very, very exquisite precision. It's got very exquisite ability to adjust your blood flow by ones or your fluid removal rate by ones. And the scales are very, very, very sensitive. This is an example of the modified ultrafiltration CVVH that we use. Essentially, you take blood from the baby, it comes to the machine, and then it goes back to the baby in a circle. You pull fluid here from the effluent, and we run this coffee filter analysis, right? We dump fluid in here at 100 mils an hour, let's say, and we take off the fluid at 100 mils an hour. And with that, we do the solvent draft. Uh-oh. Let's see. So, and what's happened with these therapies is that, as I mentioned, our goals are now much more able to be done with smaller catheters, with smaller extracorporeal volumes. We have smoother initiation and the precision that comes with these new machines. Now, one of the questions that's always asked is, well, what's in these bags that we've talked about for replacement and diffusion? Well, the first thing you have to understand is that every program does things a little bit different. And there's actually 31 flavors of dialysis fluids that you could use. It's above the ability for me to explain all that to you here today, but it's important that you understand and don't guess. You need to ask your dialysis team what's in your fluids, because it'll help you understand what to do and how to think about your electrolytes. As a basic rule, whatever is in these bags, okay, the electrolytes are going to be at steady state after a day or two. So if I want my potassium to be 4 in my patient, my potassium is usually 4 in my replacement or dialysis solution. So whatever the bags look like, that's what your patient's going to look like in a couple of days. The other thing to remember about this process is the timing. So we can choose how to do things from the perspective that we can do continuous 24 hours a day therapy, or we can do daily therapies. And you can see here that if you do that, the main difference is that the things that you're removing, the urea, the fluid, the phosphorus, the medications, are going to kind of have a zigzag pattern if you're doing it on an intermittent perspective and a more continuous approach with the renal replacement therapy. We and others are starting to do more like a kind of half a day type of therapy where you'd see this. And sometimes we do 18 hours and we give the baby a break for about 6 hours a day, depending what our goals are and our needs. So the prescription is actually a little bit more complicated than that. As a nephrologist, and I encourage you as neonatologist to talk to your nephrology team about it, but we have to think about what kind of access do we want, what machine we want to use, how long we're going to use it, what type of priming solution we're going to use, whether it's a blood prime, saline prime, or albumin prime. In general, in these smaller circuits, if you're less than 3 or 4 kilos, then you need a blood prime, but above 3 or 4 kilos, depending on the size and your program, you would use a saline prime. We have to think about what modality we're going to choose. Most of that is programmatically run, so it's not like we change from one patient to the other, whether we're going to do, the convective clearance or diffusive clearance. It's just basically what we do for all our patients and what's available for us. The clearance rates are standardized, generally about 24 mils per kilo per hour is what we end up trying to put in the effluent bag. Your program may have a slightly different approach, but those don't change from day to day. The anticoagulation process doesn't really change. We do titrate with either heparin or citrate for effect. What we do change is that intermittently we change the electrolytes, and we certainly think about ultrafiltration rates. And that's where I think a conversation with neonatology is really, really critical. And so when you have a baby on board, the things that you should be thinking about on daily rounds are, one is, what's the fluid balance that you want? What's your status? Is your patient right now have too much fluid on, have too little fluid on, or just right? What are the goals over the coming days or the goals over the next 6 hours? And what are the plans for you to achieve those goals? Remember, as you do this, that we take off about 5 to 10 cc's per hour. I'm sorry, we don't take off. The patient evaporates through their skin about 5 to 10 cc's per hour. So it's important to kind of keep that in mind when you're putting together a plan. And as one of the rules that I have is, if I'm going to take off 10% of the baby's weight in a day, that is very aggressive. Doesn't mean that I haven't done it. There's some patients that are very fluid overloaded, very hypertensive, and I need to bring their fluid down quickly. But if I'm doing 10%, I'm very mindful that that's aggressive. And again, when we do it, especially when we're doing aggressive treatment like that, it's important for us to have a dialogue up front about what we're looking for to tell us that we're pulling too much. And certainly if we're going slowly, we should think about how would we know that we're not pulling enough. So you want to be able to match your fluid removal rates and match the fluid that you're taking with a clinical impact that you're trying to affect. So if your issue is hypertension, you want to be seeing that blood pressure come down slowly. If you're trying to get fluid off because the patient has pulmonary edema, you want to be able to see that over days, you're weaning your ventilator. It's also very important to remember nutritional support. We remove about 1 to 1.5 grams per kilo per day of protein with PD and CRT. So our general rule is give whatever nutrition they need and add 1 to 1.5 grams per kilo to that when you're on CRT. Medications are very important to talk about. Medications can be removed when you have kidney failure poorly, but they can be enhanced depending on the type of dialysis that you're using. So having a conversation and having a standard for your program, I think, is important. We have a sheet that we're happy to share with anybody that kind of gives people a clue for the most common medications we use, of what type of rates we should be using for these babies. And so it's a good place to start. And then certainly, adjusting acid base and electrolytes, there's always that conversation. Are you going to change your fluids, or are we going to change our fluids? And again, having that dialogue is really important. And you can accomplish your electrolyte goals in many different ways, either by adjusting your dialysis or convective fluids, adjusting your TPN, or adding oral supplements. Communication is key. Face-to-face multidisciplinary rounds are essential, especially in kids that are complex, especially when things aren't going well. This is the time to talk about long-term goals of care, not in your note, but really having a dialogue about when is the right time to extubate or change modalities from CRT to PD, or when is the time to approach the family because things are not going as well as we'd hope. We, in our program, and I think most people, when babies are on board, we have afternoon rounds and reassessments about what are we going to do when most people leave, and we leave these kids on it in the night. And the other thing that's very important, I think, when you're doing this in babies, is to really create safety nets. Some of the things that we've done is we have twice daily weights. We have a hematocrit threshold on the Aquadex machine that's designed to stop if you start to hemoconcentrate because you're pulling too much. We have notifications for nephrology as well as neonatology if the maps start dropping or having tachycardia. And certainly, we have things in place where if the machine is not pulling as much as you think it is, or it's pulling more than you think it is, they know to call us so that we can address those things. Building a program is not easy. This is a recent publication that was done, led by Taha Good Mohammed and Jennifer Jatan and Shaina Menon, who really kind of sat and outlined what are the critical elements that are important to building a kidney support therapy program at your hospital. So I encourage you to take a read of this if you're one of those programs that wants to get started or has vision of improving the care that you're providing with dialysis. So in summary, the goals of infant dialysis are to maintain homeostasis while not causing problems and not freaking people out. Infant dialysis is indicated when the potential benefits outweigh the risks. PD and hemodialysis are different tools, and the choice is dependent on the situation. New devices are here and can reduce the risk associated with circuits designed for adults. When there's a baby on board, remember to talk about fluid goals, electrolytes, nutrition, and medications on a daily basis, and communication and safety nets are essential. So with that, I thank you and happy to entertain any questions.
Thanks, David. That was just fantastic, especially for us neonatologists who don't get to see this very often. I'm going to be very jealous, and I'm going to actually ask quite a few questions that I have. With PD catheters, how long before, once they're inserted, how long is it until you can use them? Is that time limited these days now, or can we use them straight away?
Yeah, it's a very good question, and I'll address it with two parts. I think it depends on what your goals are and what you're trying to do. So if you're trying to use low volumes and you're going to use it for a few days, sure, let's get started and you can use it right away. We do that in our cardiac ICU very often. And it works, and they're on for a couple of days. And if it leaks a little bit, they're on antibiotics and they're going to have their catheter pulled in a few days. I think in situations where you need this PD catheter as a lifeline forever and ever and ever, ideally, and you're going to place a catheter where it's cuffed in the skin, ideally you want to wait some time for it to heal. The scope guidelines recommend 2 to 3 weeks. Sometimes if you don't have the ability to do hemodialysis, you don't have that time to wait. So wait a while. I think that if you wait too long, then you're going to get yourself a mess because you're going to have a fluid overload baby without nutrition that can't heal their catheter. And so in our program, many times we'll do hemodialysis and support the baby with nutrition, et cetera, while the PD catheter is healing. And once the PD catheter heals, we transition over to PD.
Great, thanks. So there are a couple of other questions. What is the lowest weight in a baby that you've started on CRT, and what is the extracorporeal circuit volume in these babies?
So good question. So we've cared for a baby who was 1.1 kilos on CRT. My answer, though, is not really about their weight. It's really about, do we have a big enough IJ catheter that the surgeon is willing to put a line in? That's really the crux of the question for me. If you have a 1.1 kilo baby, they have an extracorporeal volume of about 80 mils per kilo. So that's about 100 mLs. And so their extracorporeal volume would be, on the Aquadex or the Carpe Diem, is going to be about 30 out of 100. So you're talking about a third of their blood volume has to come out to get them going.
Great, thanks. And one question about sort of implementation. How does your institution program support your NICU for babies on extracorporeal therapy, such as Carpe Diem, things like technicians, nephrology support? What does your team look like, I guess, that perhaps the question is asking?
Yeah, that's a great question. So in our program, our dialysis nurses are the ones that initiate the therapy. And then once the therapy is up and running, they basically pass the baton to the bedside nurses. And the bedside nurse's job is to maintain the machine and troubleshoot if there's problems. The dialysis nurse is always available for help. We also have found that having a nurse practitioner who's whose job is to help us with the acute care program, has been very, very, very valuable, not only to us, but really to everybody on the team, the surgeons, the nurses, and most importantly, the families, because she's there, Monday through Friday, every single day, whereas I'm going to be there, for a week out of every 4 months. And so she's provided a tremendous amount of support for the program in that way.
And how do you train your bedside nurses in the NICU to how do you support them, especially in that beginning phase of starting using dialysis in neonates in the NICU?
Yeah, so we have a multi-pronged approach. So our first task is to get them to a class where we would do didactics, we do skills, and we do simulation to get them up and running. And then after that, we have them come back to us every year or two for kind of a more advanced approach. And probably the most important other part is that we make it a point that every day our dialysis nurses will round on the patients, not only to see that the machine is running okay, but really to provide some support to nurses that may have not been using this for a while or maybe trained 6 months ago, to kind of help them troubleshoot, help review some of the issues that maybe they have questions about. So it's really those three things that we do.
Great. I think that's most of the questions that have come through. Thank you, David, for an absolutely fantastic talk. It's always a delight to hear you. Over to Megan to introduce our next speaker. Thanks.
Thank you. All right, our next and last speaker for the symposium today is Dr. Heidi Steflik. She is an assistant professor of pediatrics and neonatal perinatal medicine for the Medical University of South Carolina at Charleston, South Carolina. She currently studies neonatal acute kidney injury, neonatal kidney support modalities, and utilization of renal replacement therapy during neonatal extracorporeal life support. So we are very excited to have her wrap it up for us today. Dr. Steflik, you have the floor.
Hi, thanks for having me. I'm really honored to be amongst the folks speaking today, so thank you. Let's see if I can get this up and running like it's supposed to. Hopefully you're seeing my slides, and let's put it in slideshow mode. Can you see my slides and hear me okay?
Yes.
Excellent. All right, I got a very exciting topic today, in my opinion. I get to talk about BPD, PDAs, and AKI all in 25 minutes. So off we go. I do have some grant funding from Baxter. It is not pertinent for today's talk and represents no conflict. And I'm hoping that by the end, together, we're going to be able to describe the renal implications of the patent ductus arteriosus, or the PDA, and common PDA management strategies, and do the same for BPD and common BPD management strategies. So sort of two parts to today's talk. And we're going to start by talking about the PDA. So hopefully this is familiar to all of us after our pediatrics training, but we all are familiar with the fetal ductus arteriosus, or the duct. We remember that this is a blood vessel, a very small connection typically between the pulmonary artery and then the aorta. And we know that in fetal life, this diverts the cardiac output away from the lungs to help support systemic oxygenation. So there is a right to left shunt across the PDA in utero that takes that nicely oxygenated blood that comes back from the placenta and shoots across the PFO into the left atrium. That nicely oxygenated blood is able to shoot out the aorta, and it actually avoids the pulmonary circulation where the pressure is quite high. And so we have right to left shunting there that allows that oxygenated blood to make it out to the developing organs. Unfortunately, this thing can stick around after babies are born and can cause us some trouble in the neonatal intensive care unit. And in that case, we have what we refer to as a PDA. The PDA should close. So in our term babies, it closes, and it closes pretty rapidly, typically within about 72 hours of life. And even in our preterm babies, it's going to close. It's just a matter of how long it's going to take for that to close in almost all scenarios. And unfortunately, the neonatologists here are going to be familiar with the havoc that the PDA can wreak if it doesn't close right away, or if we have prolonged shunting that happens across the PDA while it's closing. So the clinical consequences of the PDA postnatally are really dependent on the degree of now left to right shunting. So rather than the pulmonary system being the high pressure system as it is in utero, now the higher pressure system is the systemic circulation, and the pulmonary resistance is dropping after delivery. And so now we get reversal of the shunting at the PDA, and we get left to right shunting. And what that does is it actually steals that circulation from the kidneys and from the gut. And that extra left to right shunting increases our QP to QS. So for every beat of the heart, there's extra blood flow going to the lungs and less blood flow going to the kidney. And we can actually see this even on our renal ultrasounds with Dopplers. If we're paying close attention, we'll sometimes even see reversal of flow in the renal arteries with that diastolic runoff. And diastole, that extra blood from the aorta shoots across the PDA and heads towards the lungs. So we have decreased cardiac output to our distal organs and increased pulmonary blood flow. The other time that we get clinical consequences from the PDA is when we, as the neonatologist, may or may not decide what sort of treatment we want to pursue for the PDA. So sometimes there's a conservative management strategy, and other times we're quite aggressive in prescribing medications like NSAIDs, indomethacin, ibuprofen, or sometimes acetaminophen to try to get this thing closed. And unfortunately, many of those medications are nephrotoxic. So let's first talk about some of the clinical consequences of the PDA related to this ductal steal phenomenon. This paper I'm particularly fond of. You'll notice that the second author and I share a last name. That's my adorable husband, Dr. David Steflik. He was a co-author on this paper, and I'm actually squatting in his lovely office today. So thanks to David for that. But he and this group from MUSC, my center, had a really interesting idea. We know that there are literature out there that support the idea of a hemodynamically significant PDA. So not all PDAs are created equal. Some of them are quite small. They don't seem to have a lot of hemodynamic significance, and we don't worry so much about those. In other cases, we have very small babies that appear to have enormous ducts, and they're very large, and there's significant gradients in flow across them, and it seems to be incredibly significant from a hemodynamic perspective. And so David and Dr. Kaufman and their group asked the question, are there echocardiographic characteristics that are associated with hemodynamic significant PDAs that might predict AKI? And so here at MUSC, they took those common characteristics that describe a hemodynamically significant PDA, exclusive left to right flow, peak gradient, PDA to LPA ratio, and they compared these characteristics between babies that did and did not develop AKI. And interestingly enough, out of all of these characteristics, only 2 of them differed between the groups. They saw that babies with AKI had more exclusive left to right PDA flow, and they had slightly higher ejection fractions. Well, these things make sense physiologically for us, because if you have exclusively left to right flow at the PDA without any return of right to left flow, you're potentially increasing that amount of ductal runoff, right? So that diastolic runoff and that ductal flow. In that case, you are also probably preloading the left ventricle. So in that case, as you have increased diastolic runoff, increased QP to QS, every beat of the heart sends more blood flow to the lungs. All of that blood flow from the lungs returns to the left atrium. And so now you've got a left-sided heart that's preloaded with extra volume, and therefore probably a higher ejection fraction. But really, the echocardiographic parameters that we typically use to determine hemodynamic significance of the duct can't reliably be used to predict AKI in neonates with moderate to large PDAs. So a very interesting study, in my opinion. What about the clinical consequences related to treating the ductus? Well, I mentioned that there's sort of 2 different treatment strategies for the ductus. Some people in some centers, many of which you all are probably at, pursue a conservative strategy where very little intervention is done for the duct. Many places don't prescribe any type of pharmacologic intervention or surgical intervention. They may or may not provide some fluid restriction, which has been reported in the literature to be associated with ductal closure. And that's really all that they're going to do. And so this group here from Asia examined this question about, in very preterm babies, 23 to 26 weeks, how is conservative management associated with AKI or not? They studied 97 patients. See if I can move this. I don't know if you guys are seeing this too. They studied 97 neonates, and they broke them into 2 gestational age groups, 23 to 24 weekers and 25 to 26 weekers. Here's a really beautiful figure from that paper that looks at the prevalence of AKI. They examined AKI over the 6 weeks of life in these first two groups, and they had very high incidence rates of AKI. So the 23 to 24 weekers, 72% of them experienced stage 3 KDIGO, stage 3 AKI, and 57% of the older group. And we see that in all cases, the smaller, younger gestational age patients had higher rates of significant AKI. And we see that those differences between groups was statistically significant at week 2, week 4, and week 6. But also that the peak prevalence of significant AKI was in the second week of life for these babies. They did some adjusted analysis and they looked for the risk of adverse outcomes, mortality, BPD, IVH, PVL, all of those abbreviations that we love in the NICU. They looked for risk of those adverse events by the presence of stage 3 AKI or not. And very interestingly, they found that the adjusted odds for risk of unfavorable outcomes was not increased in the stage 3 AKIs in multivariable analysis. So even though these patients are developing quite severe AKI, it didn't seem to impact their long-term outcomes that we worry about in the NICU. So maybe a little different than some of the other AKI literature out there, but an interesting look in patients with moderate to large PDAs, managed conservatively. One of the other papers I want to share with you is this one from Dr. Majid. I hope I'm getting that name pronunciation right. But here we looked at those patients that we're going to medically treat. So first we looked at the echo predictors and what is that ductal shunt doing. Now we've looked at conservative management. What does conservative management have to do with AKI rates? And now let's investigate the association between AKI, the timing and duration of the duct being open, NSAID and other nephrotoxic medication exposures, and a few other covariates. So they did this in a single center, and they did it in babies that were less than 28 weeks of gestation, less than 30 days old, and had echo confirmed moderate to large PDAs. When you look at some of the characteristics of these patients, so they enrolled 206 patients in total, and about 50% or so developed AKI. And we see that the patients with AKI had higher rates of PDA associated worsening in their respiratory status. They had higher receipt of NSAID therapy and were younger when they started that NSAID therapy. Interestingly, they had lower cumulative doses of indomethacin, and I think that probably gets at different centers' strategies for medical management of the PDA. And they found that those that had AKI had higher rates of PDA ligation in the first month, but ultimately lower rates of persistence of the PDA. So potentially there's a handoff here. You have less PDA to deal with in the second and third month of life, but higher amounts of AKI in the first month of life. In their multivariable analysis, they showed that young gestational age, young chronologic age, less than 10 days of life, a PDA, NSAID receipt, vancomycin or gentamicin receipt, and hypotension were all independently associated with any stage AKI in these babies in the first month of life. And specifically, if we want to see the odds ratios for PDA and AKI, PDA was associated with stage 1 AKI, but very strongly associated with severe stage 2 or stage 3 KDIGO AKI with an odds ratio of nearly 11. Here's the really interesting part of this study, in my opinion. They found that in patients who had effective NSAID treatment, so the NSAID achieved that PDA closure that we were looking for, which really only happens about 50% of the time, that effective NSAID treatment decreased the risk of severe but not mild AKI. So babies with severe AKI were less likely, to develop severe AKI when the NSAID was effective, but not when the NSAID was ineffective. I think this is the final big study I want to share with you about PDAs and AKI today before we move on. But this was a secondary analysis that was just recently published by many of my mentors. It was a secondary look at the Awaken cohort, which hopefully you're familiar with from some of the talks earlier today. They took all the patients in Awaken, and about 550 of them had PDAs to look at, or had data around PDA to look at. And they divided those patients into groups based on how the PDA was addressed. So a group for no treatment, a group with medical treatment, and a group for surgical treatment. And those had about 60 patients in each one. And they looked at the odds of AKI based on the PDA management strategy. And they found no differences in treatment cohorts in the odds of AKI. So in looking at Awaken, it doesn't seem to matter which treatment group you fall into in terms of AKI outcomes. But in other studies that have recently been published, we see very strong associations between these nephrotoxic meds that we use to address the PDA and AKI. So in RAC News paper that recently was published in Pharmacy Practice, the incidence of AKI among infants who received indomethacin for the PDA was double that than in indomethacin non-exposed infants. Similarly, Constance et al. Found that among patients with PDA receiving NSAIDs, there was an increased risk of AKI compared to non-receivers. And in another paper that I wish I had time to dive into, but time is short today, there was an independent association between AKI and the use of gentamicin, which is pretty common for us in our VLBW babies, who also required ibuprofen or surgery for their PDA. So now we're talking about concurrent nephrotoxic exposures in very low birth weight babies with susceptibility to AKI, and we're seeing a strong odds ratio for AKI in those patients. So really, after 15 minutes of talking about PDA and AKI, I think the answer is it's clear as mud. It's a Southern saying for those of you that don't live in the Southeast United States, but in something's a little bit confounded and not quite clear, we say that it's clear as mud. So is it the underlying physiology of the PDA? Is it the treatment modality that we choose for the PDA? It's really hard to say. This is certainly an area for the trainees that are here today that are interested in neonatal AKI or interested in the PDA that is ripe for us to really learn more about. Maybe a little bit of self-proclamation here, but some of my mentors, Dr. Jatan, who's not able to join us today, and Dr. Selesky and I were fortunate enough to be able to work on a project recently where we did a collaborative between myself, the neonatologist, and them, the nephrology colleagues, and some of their colleagues. And we wrote a couple of clinical scenarios where it's really important that we collaborate and we look at nephrotoxic medication exposures and the necessity for those in the ICU and sort of AKI from both the neonatologist perspective and the nephrologist perspective. So if this interests you, this idea about PDA and AKI, we have a case scenario there that I'll refer you to have a little deeper look. So let's shift gears just a little bit here and talk about BPD briefly. Hopefully this chest x-ray strikes fear in the hearts of all of the neonatologists and neonatology trainees on the line. This is what we are hoping to avoid, right? And BPD is really an ever-changing phenomenon for us in the NICU. There was historically this idea of old BPD that happened in moderate and severely preterm babies. And we really thought that this was due to injury and fibrosis that was caused from oxygen toxicity and that ventilator sort of beating up the patient's lungs. But really, as our therapies in the NICU are improving and our more premature infants are surviving longer and longer, we're learning about a new concept for BPD, where really mechanical ventilation and oxygen toxicity play a role, but they're not the primary drivers of BPD. Really, this uniform arrested development of the alveoli and the associated vasculature is what's leading to the clinical outcome that we see of BPD. For those neonatology trainees in the audience who are prepping for their boards, you'll remember our 5 stages of lung development, the embryonic, pseudoglandular, craniolicular, saccular, and alveolar stages. Every preemie can survive always, to remember those. And we see that old BPD was really happening in the alveolar stage at the end of development, and when we were sort of beating up those lungs is how we thought of it. But now we're really coming to understand that when our 22, 23, and 24 weekers are born in that canalicular phase, the new BPD is really related to that arrested growth that those patients are experiencing. So certainly prenatal events, in utero growth restriction, infections, birth-related events, small for gestational age at birth, premature birth, and then the postnatal complications that we talk about all contribute, but BPD is probably alveolar simplification with pulmonary vascular dysgenesis driving it. And all of these inflammatory markers are modulating the development of chronic lung disease. There are multiple iterations of ways to diagnose BPD. This is the result of the most recent NICHD work group on this, but really the definition is for babies less than 32 weeks who have persistent parenchymal lung disease, radiographic findings of that lung disease, and at 36 weeks post-menstrual age require one of the following. So either intermittent positive pressure ventilation, CPAP, nasal cannula, oxygen supplementation, and we use these varying amounts of support to determine what type and how significant their AKI is. So much like we have the modified neonatal KDIGO criteria, we have the NICHD work group criteria for BPD staging. So I have just, I think, 2 or 3 papers to share with you about BPD before we wrap up for the day. The first is from the speaker who preceded me, Dr. Ashkenazi. This is a really beautiful project that he and his group did back in 2015. They did a prospective look at very low birth weight infants who were less than 1,200 grams and less than 31 weeks. And to my knowledge, this is the very first look for any type of association between AKI and BPD and mortality. The animal studies in the mid-2000s and 2010s were showing us that there was probably a lot of crosstalk between the kidneys and other organs, including the lungs, but it hadn't been investigated in neonates. And so he and his group chose to tackle this, which is not a small project. They had 2 hypotheses. Their first was that AKI would be independently associated with BPD and mortality. And to look at that, they assessed both the need for oxygen, which you see here, and the need for the ventilator at both 28 days of life and at 36 weeks postmenstrual age. Their second hypothesis was that AKI would be independently associated with longer duration of oxygen supplementation in survivors who lived to 28 days of life. And so here we see that cross tabs between oxygen support or death at those various time points and mechanical ventilation and death in those various time points. And we see that across the board, those are all more frequent in patients that have AKI. When they looked at the relative risk, both the crude and the adjusted risk for oxygen support or death at 28 days and at 36 weeks postmenstrual age, they found that in patients with AKI, they had a significantly higher odds ratio, relative risk, So those with AKI by day 15 had a 71% higher risk of oxygen requirement or death by day of life 28. And this remained after controlling for confounders. Unfortunately, we didn't see the similar finding at 36 weeks. But it's a very similar pattern when we look for associations between mechanical ventilation or death. Again, those with AKI by day of life 15 had a significantly higher, almost a double risk of oxygen requirement, of mechanical ventilation or death by day of life 28. And this held up in multivariable analysis as well. They also looked at the hazards. So over time, looking at discontinuation of oxygen therapy. And so in those without AKI, there was a 2.5-fold increased hazard for more likely to be coming off of oxygen than in those with AKI. And this remains true as well, even after controlling for confounders. So the absence of AKI predicted you being able to separate from oxygen therapy. Dr. Starr picked up the task from this and worked on another project with the NKC and Dr. Ashkenazi, again, examining this idea that there's a relationship between BPD and AKI. She did it in a secondary analysis of the AWAKEN cohort. You can see we're getting to use that cohort in many different ways to inform lots of neonatal questions. And here, again, she wanted to examine associations between AKI and moderate or severe BPD and death. The AKI rate in her population was about 33%, which is what we would expect from the broader AWAKEN cohort. And about 246 or 45% of the 550 or so patients had moderate severe BPD or death. And we see that the odds of AKI was significantly higher. There was an association between AKI and moderate or severe BPD or death. AKI was 5 times more likely in those with moderate severe BPD or death. And also higher stage AKI was also more common in those with AKI. In their analysis examining BPD or death, their multivariable analysis, those with moderate severe BPD or death was associated with a 2-fold increased likelihood of developing AKI. And this was true both in their entire cohort here that you see at the top in all 546, but also true in the patients that were 29 to 32 weeks, but not true in the severely preterm infants less than 29 weeks. I wanted to draw your attention to this very nice review article in a nursing journal, actually, about the impacts of diuretic therapy for BPD and AKI. We are just starting to understand the impacts of the treatment of BPD with diuretics and how that might relate to the kidney. We have a great deal to learn about this, and this review article very nicely describes what we know and what we still need to study. And then the last paper that I have to share with you today is another paper from Dr. Mohammed, who I know Dr. Ashkenazi also cited. This was a Children's Hospital Association FIS database investigation, and really an epidemiologic study to quantify the frequency of diuretic use and the prescription patterns in preterm infants across the board, but especially those with AKI, and to investigate relationships between some of the outcomes that we tend to care about: length of stay, mechanical ventilation, and mortality in preterm infants with AKI. So between June of 2015 and I think it was December of 2019, there are almost 233,000 babies in the FIS database. When they narrowed that down to just infants admitted to the NICU within a week of life, and those that were less than 37 weeks, it came down to about 71,000 patients. The AKI group was much smaller than the no AKI group, which we know can take place in large databases like this. And then they examined diuretic utilization in the AKI group and diuretic utilization in the no AKI group. And we see that in the AKI group, diuretic utilization was incredibly common at 76% compared to only 16% in the non-AKI group. And if you combined all of the patients in their cohort who received diuretics and you look, 99% of the diuretic provided was furosemide. When they looked at median duration of diuretics across the cohort, it was for about 18 days. So these are not babies that are typically getting a spot dose or 1 or 2 doses of Lasix here and there, but really these are patients that are being exposed multiple times for multiple consecutive days. And they did a really nice analysis of looking at the AKI patients with no diuretics compared to the AKI patients with diuretics. And they found that in neonates with AKI, diuretic use was associated with significant length of stay increases, nearly tripled length of stay, significant increase in the need for mechanical ventilation, and significant increase in mortality. Unfortunately, we need a lot more data about this. We don't know very much about how diuretic and other treatment modalities for BPD impact AKI or renal health. And Dr. Seeger and Dr. Jatan just wrote a really nice kind of call for evidence-based guidelines that was published in Pediatric Nephrology less than a year ago. And if you haven't read this, I would encourage you to take a look. So in summary, the renal consequences of the PDA are related to the degree of left to right shunting and the subsequent ductal steal that we discussed, but as well as the treatments targeted to close the PDA. Those nephrotoxic meds are certainly having an impact. The PDA is also associated with all stages of AKI and neonatal AKI. And unfortunately, our echocardiographic parameters are of little help in predicting whether AKI will occur or not. However, clear as mud. It remains unclear how differing management strategies, conservative strategies, medical strategies, surgical strategies impact AKI rates, though we know that nephrotoxic medication exposures are strongly linked to AKI in all neonatal populations, even those with PDA. When we talk about BPD, there's less to summarize because we just have a lot less knowledge. We have a lot fewer papers and manuscripts out there to evaluate, but we are seeing from Dr. Starr and from Dr. Ashkenazi that in premature neonates, there is an association between AKI and BPD mortality composite outcome. I haven't seen a paper yet looking at just BPD. And we also know that in premature infants with AKI, diuretic exposure is incredibly frequent and associated with increased mortality, length of stay, and need for mechanical ventilation. So with that, I thank you again to the organizers for having me. I'm really honored to be here today. I thank all of you for attending, and I'd be very happy to take a few questions before we wrap up for the evening.
Thank you, Heidi. And I want to jump in because I'm remiss that I did not introduce Dr. Kent at the beginning of this symposium, since she is not only one of the committee co-chairs for the NKC hosting this, but definitely the reason we are all gathered here today. So Dr. Kent is an adjunct professor of pediatrics for the University of Rochester. She, like many of the other neonatologists and nephrologists on this call, have an interest in kidney development and acute kidney injury. She has developed an animal model of HIE and AKI and is a member of the Neonatal Acute Kidney Injury Australia and New Zealand study examining the incidence of AKI in neonates, which is why she's got a cool accent. So Dr. Kent is going to now really answer, has some questions for Heidi, but also take us into our end of session question and answer time. So feel free, if you are having issues with the chat function on YouTube, refresh your screen and it should come back up, and put your questions in there so that we can get those covered.
Right, thanks very much, Megan, and thanks, Heidi, for a great talk. I'm just wondering about the use of PDA medications. There's obviously differences between countries, and having now worked in both the US and in Australia, the use of indomethacin in Australia is probably almost non-existent now. Partly that was beneficial that they stopped producing indomethacin in countries, so we had to use alternates. Do you know whether people are sort of looking at paracetamol now and the incidence of PDA with and AKI with that different modality of treatment, which hopefully should have less nephrotoxic consequences?
Yes, so that's a great question and something we're actually looking at our own center right now. We recently revamped our own PDA management guidelines within the last 4 or 5 years. And so we're just looking at pre and post cohorts from that implementation. But acetaminophen is becoming increasingly common because it has fewer side effects. We don't have to worry about the nephrotoxicity. We don't have to worry about the GI side effects. But there are some unanswered questions about acetaminophen exposure in neonates and later development of behavioral problems like autism that are certainly giving people some pause. But there's a very nice JAMA article from, I want to say 2019, that compared ibuprofen, indomethacin, and acetaminophen. And acetaminophen is just as effective in achieving PDA closure as any other option. So certainly we're using it as first-line therapy at MUSC, and I suspect that that's becoming much more common across the country here in the United States. I can't speak to Australia.
Excellent. I think many centres in Australia will be using paracetamol as their first-line treatment, and then using ibuprofen as a second line if paracetamol hasn't been successful. So I think that's definitely a change in practice, and it'll be interesting if anyone wants to put into the chat perhaps what their countries are doing that they know of.
Wouldn't it be a great project if someone were to publish on their outcomes around AKI and acetaminophen use? Wouldn't that be great?
Exactly. We can hope. We can hope. So, Andrew, one question. I was just sort of wondering what can be done to prevent ongoing nephron loss in infancy and childhood in those that we've known have had an acute kidney injury or have a good setup for having fetal growth restriction and other issues that may have occurred in that prenatal and postnatal period, to kind of reduce that risk of having long-term kidney disease? I'm just sort of wondering whether you've got sort of any thoughts on that.
Thank you, Alison. Yeah, I have lots of comments and thoughts, but unfortunately no answers. So as far as I know, there is absolutely no way to improve long-term kidney outcomes in people who, quote unquote, have subclinical kidney disease, meaning they have a normal GFR or slightly decreased GFR, and they have no proteinuria. So we have no therapeutics that can delay the progression of CKD or prevent development of CKD. So what we're stuck with is preventing or mitigating new insults to the kidney. So from a general population standpoint, it's all your typical stuff: avoiding cardiovascular disease risk, especially with obesity. There's pretty good data, and I went through that slide quickly, but in our preterm birth cohort, we have data both for albuminuria as well as mechanistically changes in the renin-angiotensin system with antenatal programming of disease, that obesity does in fact act as a second hit and amplifies preterm-term differences that otherwise would be more mild. But just short of those kind of lifestyle modifications and avoid or mitigating ongoing kidney injury in more acute settings, if the kids are ever hospitalized again, we really don't have anything. So that's why it's so important to be really clear if these are true causal risk factors, because I can't in good conscience promote a new therapeutic if we don't know for sure that there's an actual problem that's going to develop years down the road. So it's a fascinating topic for discussion, but yeah, unfortunately, we don't have any therapeutic options at this time.
Great, thanks, Andrew. Minna, we're just sort of thinking about acute kidney injury. Are there ways that you think that we can detect AKI earlier than what we're potentially doing, and so that we can reduce the impact that acute kidney injury could have? I'm just sort of wondering whether there's anything that you're doing in your unit or what suggestions you might have as far as that's concerned.
Yeah, I think the biggest thing is frequent monitoring. I trained in a place where we didn't used to check creatinine frequently, and then when I joined here, creatinine is part of the panel that we used to check electrolytes every day. So it's not necessarily we're drawing extra blood to check creatinine on those babies. And I think if we're checking frequently, especially in the high risk groups, we can detect it early and change our management to improve outcomes.
Thanks, Mina. Question 3 for Heidi. About diuretics, sometimes we use theophylline for the indirect diuretic function. Has there been any information about how this is related with worse evolution of BPD and acute kidney injury?
That's a good question. The only papers that I know about, and maybe someone else on the call knows more than I do, but the only papers that I know about that inform theophylline and AKI are in an HIE population. And most of those have been done outside of the country, and they've been done in patients who aren't receiving therapeutic hypothermia. So there's still a lot of questions about theophylline and AKI. I don't know about its use for BPD as an indirect diuretic and subsequent AKI. I don't know that that's been published on.
Yeah, I guess caffeine sort of really is in that same group of medications, and the interesting aspect of that whole sort of mixture is that caffeine supposedly reduces AKI in certainly that preterm population, but then there doesn't seem to be the related benefit with BPD. So it's all a bit of a mixed picture, isn't it? So no.
Yeah, I know Matt Harrer and Dr. Charlton are working on the caffeine picture and AKI, but I don't know about doing it for BPD.
Yeah. So I guess in relationship to that, is there any sort of indication of the timing of acute kidney injury and the development of BPD? Is it something that we see if it happens early or if it happens later? Do we have any sort of information about that?
Truly, the papers I presented from Dr. Ashkenazi and Dr. Starr are the most that we know about the association between AKI and BPD development. There was a recent NRN study looking at diuretic use and safety. Unfortunately, it didn't look at any kidney outcomes, and Dr. Ashkenazi made some excellent points about that at PAS this past year, but we don't have a lot of information about the timing.
Excellent. And David, sort of one last question I have. How do you work out TPN requirements with CRRT? How do you sort of mix those two?
Yeah, so the one nice thing about continuous modality is that you can give as much fluid as you need. So we take the approach of, give as much calories as you need, give as much proteins as you need, add an extra, gram per kilo or 2 of protein. We make sure that our BUN isn't too low. We like to keep our BUN in the 40s to 60 range as a sign that we're giving enough protein. And we take the fluid off. We certainly we prefer oral. I mean, there's lots of data that says, oral feeds are better than TPN. And so there's always that conversation back and forth about, when can we transition to oral? But we make it a point that we're very focused on nutrition, because otherwise you're kind of spinning your wheels and you're taking care of kids that if they're not growing, then you're just kind of leaving them in the NICU longer. And they won't be able to leave.
Excellent. Well, I sort of definitely want to say thank you to all of our wonderful speakers, and thanks to everyone who's attended. We've been really thrilled by the number of people who've shown such great interest in neonatal kidney health. If you could sort of think about answering the post-symposium questionnaires, so if you can use this QR code here to do the post-symposium, and if there are any other questions, please pop them in the chat while we continue to have a few more questions. Heidi, I was just sort of wondering about guided therapy for echoes for PDAs. I think that's something that in Australia neonatologists do a lot of, that neonatologists are trained in doing what we call clinician performed ultrasound. And we have sort of fairly strict criteria of which PDAs we then treat and which we don't. Do you think that has an influence, and do you think is any of that coming up with any of the work that you're doing in the US?
Yes. So functional echo at the bedside and echo performed by neonatology specifically to evaluate the duct is sort of a hot topic right now in the US. POCUS in general, or bedside utilization of ultrasound for a variety of different reasons in neonatology, is becoming something that's sort of interest to a lot of different people. There are a couple of centers that are really good at it. Iowa comes to mind as being one of those centers where the neonatologists are using echo regularly, multiple times a day, to guide not only PDA management, also pressure management, ventilator management, and those sorts of things. I think it's coming. I think we're not there yet, but it's coming.
Great, thanks. And with David, when you're sort of doing changing over from PD, from CRT perhaps to PD, how do you think about the sort of fluid shifts and the differences that you're going to have to do from doing CRT to PD?
If I understand your question, I think that, you know, in PD, it's more of a guesswork, right? I'm going to use 2.5%, and I think I'm going to get 400 mils out in the next 24 hours. And then you come around maybe once or twice and see if that's really the case. In CRT, it's more of kind of an hour-to-hour prescription in many programs. And so you can just dial the knob anytime you want to say, okay, I want 20 this hour, I want 40 this hour, or, you know, I want to turn it back to 0. So I think that's one of the differences, is that your control for fluid is a little bit tighter with a blood, you know, with a blood circuit.
Okay, great. So I think the survey might have expired. Is that correct, Heidi? Is that what you were saying?
Yeah, I was just trying to access it just to have a look, and it tells me that the survey has already expired, unfortunately. So just wanted to give you guys a heads up.
Megan, you may sort of be able to fix that up, and people can still do it a little bit later.
And try again. So let me try again here and see if I can make it work, because I think that's a great. Yep, now it's working. Thanks, Megan. That's great.
Excellent. So if everyone can do that, that's great. Thank you. So I think we've just got some wrap-ups of the take-home messages for everybody. So I think from Andrew's talk from Kidney Development, Prematurity and Neonatal Insults, the most important things that we can remember is that postnatal kidney structure and function are immature, so anticipate that we are potentially going to have some problems. And so we just need to be aware of that. Early life programming of chronic kidney disease is incredibly complex, so we have lots to think about through those causal relationships. And neonatal AKI, it's common in neonates with some high-risk groups, those who are preterm, who've got HIE, who are on ECMO, or have congenital heart disease. And it is associated with mortality and high risk for other morbidities, such as longer duration of stay and ventilation, intraventricular hemorrhages and BPD, and fluid overload. So I think it's one of those really important things that we have to remember, that kidneys are important now, and we know that they're an independent risk for mortality. And David's made neonatal dialysis easy today, and to remember that the goals of infant dialysis are to maintain homeostasis while not causing problems and to not freak people out. Program development and care of infants on dialysis requires neonatologists and nephrologists, and as David said, is just a really big team effort. The kidney and PDA and BPD, we have to remember that the renal consequences of the PDA can be related to both the management and targeted closure of the duct, and however, it remains unclear how differing management strategies, conservative versus medical versus surgical, impacts our AKI rates. And it will be interesting to see what happens now with some centres doing a lot more percutaneous PDA closures as well. And we're just beginning to understand the association with BPD, diuretic exposure and acute kidney injury in premature infants, and lots remain to be learned. So again, let us know what you think about the symposium. Please do the post-symposium questionnaire and let us know any topics that you'd like in the future. Please consider becoming a member of the NKC. And as David put up, there's the workshop, postgraduate course that's being held before PAS on the Friday. Please feel free to join that group. And also that these are the next courses for 2023. There's one that's virtual, and then there's two that are in person. So even if you're on another side of the world from Alabama, that you are able to attend the next course virtually. And please utilise the NKC website for research and education information and updates. And I'd like to again thank everyone for their enthusiasm and attendance today. And Megan, I think at last, has the prize winners for today. So I'll throw it to you, Megan, to let everyone know who's won prizes, and then we'll close.
Yes, we do. And I see some people are jumping off, so apologies if you have already gotten off. Incidentally, we did a generator online, and the two people that won are actually the two people that asked us questions on YouTube at the beginning of the symposium. So I apologize if I butcher your names. Please correct me, but I'll be emailing you afterwards. It's Ibrahim Olinka and Nadia McLean from Jamaica and Nigeria. You guys have gotten free registration to our next course. So assuming you don't want to fly to the continental US, you can join us for the June virtual course, and we would be excited to host you. Again, thank you everyone that has come today. It has been